I would say 90% of the patients that come in here are skeptical.
Mm-hmm.
Most of them are. I was skeptical when I first saw the machine.
Right.
I'm like, what the hell is this thing?
Right. I was skeptical too.
Yeah.
I can tell you that much.
But when you like really think about what it's doing, like, oh, okay, well, that makes sense. So we have a shortage of this. How do we make more? Oh, we stimulate the brain to make more. Like, it makes perfect logical sense when you really think about it.
Hi, this is Tim Westbrook. Welcome to I Love Being Sober. We talk about life and recovery, mental health, biohacking, alternative therapies, and everything related to living a kick-ass sober life. So let's dig in. Hey everyone, I'm Tim Westbrook. Welcome back to another episode of I Love Being Sober. Today I'm joined by Dr. Robbie Westerman. He's a brilliant physician and mental health advocate, and he also has an incredible story of transformation. We call him Dr. Robbie. His name is Dr. Robert Westerman. And before he was a doctor, he was just Robbie, a hopeless drug addict and alcoholic. And you can refer back to another interview that I did with him about 3 years ago,
Probably,
if you want to hear more about his story. But he's one of the most brilliant psych providers that I know of. He works with us. He's a partner with us at Camelback Integrated Health and Wellness. He provides services at Camelback Recovery as well. And today we're going to talk about transcranial magnetic stimulation and then any of the other new modalities that are working these days. So let's talk about TMS. So Robbie, for people that don't know, what is transcranial magnetic stimulation, or also known as TMS, and how does it work?
Gotcha. Well, first, let me correct you. I'm not a physician.
Okay,
before they all hate on me when they watch this, okay? So I have a doctorate degree from University of Arizona in psychiatric nurse practitioning. So I am a nurse, advanced practice nurse with a doctorate degree, so a lot of extra training. But transcranial magnetic stimulation essentially is a treatment that involves the use of magnets. So it's not really electricity like we see ECT, but uses magnets to depolarize, and that's a fancy word for fire or turn on, and polarize, turn off, neurotransmitters in the brain over and over and over again. So when we look at different mental health ailments, we look at depression, we look at anxiety, we look at OCD, we look at PTSD. We know most of those ailments have to do with neurotransmitter imbalance. So we know that people with anxiety, they perhaps have too much of a chemical we call glutamate, right? So people with depression, they may have not enough serotonin, they may not have enough epinephrine or dopamine. So all of these neurotransmitters, they're basically little electrically controlled particles, okay? And what TMS does essentially is it fires them over and over and over again, and the body is identifying where it has shortages of. So, hey, we need to make more, and where it has deficits in.
Okay. And then how do you know that someone has deficits?
Yeah, good question. So typically, and this is usually for treatment-resistant depression, for most people, they've tried a few things before they just jump into TMS. So more often than not, they've tried psychotherapy, they've tried, a couple different medication trials, and, they haven't had any success with any of these trials. So let's kind of get into a little bit of kind of how we would identify where the shortfalls are and what we would do for them. So as a psych provider, our job is to identify, what ailment they have, what subtype of ailment they have. So when we look at depression, we mainly think of people that are just like really mopey, they're really sad, they have low energy, low motivation, just kind of in the dark, in their room, won't get out of the bed, don't want to be around anyone, 5 o'clock shadow, right? Eating Oreos, right? Those kind of images come into your head. But in actuality, there's a ton of different subtypes of depression. So we see people that they're fine, they're able to get up, they're able to go to work, but they may just be very sad inside. And those kind of things are hard to find out sometimes without really knowing the patient, interviewing them long enough, really getting down to the details. And then you have the people that are, they're not able to get out of bed. They're very energetic. So they're not able to get moving. They're not able to get motivated. Then you have people that have anxious depression, right? They're just very nervous, very on edge, racing thoughts, right? And that really takes a toll just having those racing thoughts running through their head and those doubts, insecurities going all the time, it really like bogs the brain down. So as a provider, our job is to identify like what type they may have. And then based on that type, we pick what agent or pharmaceutic may be best for that patient and their subtype. So somebody that has a or flat depression, so they're really sad, but they're able to get up and get moving, we'd probably give them something that works on serotonin. Someone that's very tired, we'd probably give them something that works more on norepinephrine or dopamine. Sometimes we use classes that work on all of them. But if you look at all the different medication classes and what they do, and then all the different subtypes of depression, there's like 5,000 permutations of like how things can go wrong. So you pick the wrong subtype of depression, then you're using all these medications that, hey, we're going to use Prozac, we're going to use Zoloft, we're going to use Celexa, we're going to use Paxil, right? We had all these different meds. Those are all in the same class. So typically a psych provider's, put them on the medication for 4 weeks, raise the dose, 4 weeks later, raise the dose, 4 weeks later, raise the dose. Med's not working. Switch to different med, 4 weeks, raise the dose, 4 weeks, raise the dose. Not working. Okay, different med, 4 weeks, and you're doing that forever. And you haven't even jumped to another class of medications yet, right? You haven't jumped to the meds that work on norepinephrine or on dopamine. You're just on serotonin still. So people can kind of be stuck in that rut for a really long time, like trying different things. And, depending on your body's makeup, some meds don't work for you. So we have people with different enzymatic problems, so different CYP enzymes, we call them. So they're not able to break down medications properly. So that's why we rotate different medications. So with all that being said, what TMS allows us to do is we don't even have to identify correctly what subtype it is. We don't have to know if it's an anxious depression or if it's like an inertic depression or if, it's whatever kind of depression, just a flat affect type depression, because what TMS does is it stimulates everything. So we're stimulating dopamine, norepinephrine, serotonin, right? We're hitting every separate neurotransmitter, glutamate. So by hitting everything, we're taking out the guesswork and taking out that, I guess, the vulnerability in the system of either we have a problem with the diagnosis, which is common, or we have a problem with the agent, which is also common. That's why antidepressants, they say, they're 30% effective. It's not because they don't work. It's because it's so darn hard to figure out exactly what the patient has exactly for that patient, and then what medication works for their body. So TMS, it kind of eliminates the guesswork because it's like, all right, well, let's not try to guess what they have. Let's just target everything. Mm-hmm. Let's target everything involved with depression.
So what percentage of people does TMS work on?
So I've been doing TMS for, 6 years now, and I've treated thousands and thousands and thousands of patients with TMS. I personally, and this is my personal experience, and I'll share why I think, I've never had somebody not respond to TMS. Never. Now I hear it sometimes. TMS is FDA approved for 36 sessions. So basically, to get FDA approval on a medication, product, equipment, get insurance approval, you have to show enough separation from placebo or sham, right, to say that, hey, this works. So if I give somebody a sham TMS and give somebody real TMS, and the person that's getting the real TMS, their PHQ-9 or their depression index score improves by 5 points, the device manufacturer can say, hey, look, FDA, our machine beat sham, right, by 5 points, and that's enough to get approval oftentimes. But it doesn't say it's not to say that doing more will make you better, right? Okay. In insurance, I don't want to pay more. It's not like, okay, hey, 36 will get you 4 points. It's like, okay, well, will 60 sessions get you up 8 points? Maybe, but that's not how things get approved. It's like, they don't ask how much better can they get. It's like, did they get enough to meet approval? Right. That's it.
Right.
So, for instance, here at Camelback, what we do instead of the 36 typical sessions, and we have a lot of late responders with TMS. Some people don't start responding until 30 sessions. So people respond late, it's very common. I see this all the time. We give everyone 72 sessions.
So let's go back for a second. So tell me about the late, like why do some people respond late versus some people that respond early? What? Tell me about that.
So everyone's neurotransmitters are different. So, I have different theories about why people respond late. Sometimes we may have someone that's very anxious, at first. So there's some people you can turn the machine up really high and you get no movement, like when you're firing the stimulator. And then some people, you turn the machine just barely on and they're, kind of flailing around a little bit. And you're like, okay, wow, they're really activated. So if you have someone that has that anxiety on top of the depression, sometimes it takes a little longer to get through that anxiety first before you can really crank that machine up to start working on the depression. Okay. So you have to go through that anxiety first. You can't just crank up the machine, right? They'll start flailing around. It'll be very uncomfortable. Okay. So some people, if you have that really twitchy kind of anxiety with the machine, it takes more sessions to kind of work through that before you can really start getting to the depression, which is you got to, we call it remapping. So we have to remap the patient 15, 20 sessions in, and you notice they're less responsive to the TMS after 15, 20 sessions. Okay. And then that gives me the cue, okay, we're kind of working through the anxiety. Now we're going to work through the depression. So, and we see it the other way too. So that's kind of my theory and why people may be late responders. And then helmet placements. Are they getting the right dose delivered? What kind of medications are they on? Did they have alcohol intake that day? There's so many different variables, but to eliminate all those variables, what I do and I found effective, I take that back. I've had one retreatment, but I offered just to give her 20 sessions for free as like a touch up 2 years later. But I've never had a patient need a retreatment. Okay. Insurance will cover it too. It's a bad business model for us, to not do the retreatment, not a good business model. And giving the extra sessions, obviously there's a cost there. But I think if you give a patient enough treatments and they're consistent enough and they finish all 72 sessions and, just what I've seen anecdotally, we really don't have to do retreatments.
You say 72 sessions and FDA cleared for 36 sessions. How do you provide the 72 sessions?
Yeah, so
that said, they have to come here 72 times?
Nope.
Or how does it work?
Exactly. Good question. So insurance, for the most part, we'll start with insurance first because they dominate everything, of course. Insurance approves one 20-minute session 5 days a week over the course of 6 weeks, okay?
Okay.
With one little taper week and one onboarding week, which is a 3-week ramp up and a 3-week taper down, and then you have the 30 sessions smashed in between. Mm-hmm. So it's typically 3 days a week and then 5 days a week for 6 weeks and then 3 day a week taper. So that's to get paid from insurance, and to submit a billable claim, you have to follow the protocol. That's a 20-minute session. What we do is, we can do a lot of different things. If they're utilizing insurance, what we will do is we will provide them a theta burst session after their 20-minute session, free of charge.
Okay.
So basically, everyone gets a session, and then they get another session right after.
Okay. And then the theta burst. Tell me about that. So the regular session's 20 minutes.
Yep.
And then tell me about the theta burst.
So the theta burst is essentially the same thing as TMS. It's just quicker. So a normal TMS machine, you hear the tap, the magnets firing, you hear tap, 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 tap. And with theta burst, you hear drr, drr, drr. So essentially you're getting the same amount of bursts in a way condensed period of time. In the literature, you can look up the literature. There's great literature that it's just as effective as standard.
So why would
TMS.
Somebody not want to just do theta burst? Why do the 20-minute session?
Insurance coverage.
Insurance
so cash
coverage.
pay,
Okay.
You get a lot of flexibility.
So insurance, they've got to use the deep TMS, the 20-minute sessions.
Yep.
But if they're cash pay, you can do 100% theta burst.
Yeah. So if they're and you get a lot more flexibility because you're no longer limited to one session per day. If somebody's cash paying, we give people 10 sessions per day. Mm-hmm. So we can give them 3-minute theta burst sessions in a row, and then we wait an hour and do it again. So a lot of people, they come in, and if they cash pay, they can get 9 to 12 sessions done a day. And then over the course of 2 weeks, they can complete their entire TMS treatment, because people got vacation plans. They got, it's hard to commit 8 weeks. That's a lot to ask of somebody to come into the clinic for 8 weeks almost every day. Mm-hmm.
Well, I think to your point, there's just more flexibility. If someone wants to get it done more quickly, they can just focus for a couple of weeks and get the entire thing done. Regardless, I mean, or if they come in, they don't have to come in for long. They can come in and have these theta burst sessions back to back to back, and get through it more quickly.
And I love the flexibility of doing that. And in all honesty and practicality, insurance pays a lot more than what we charge for cash. So insurance pays a heck of a lot more. Like financially, it's like, well, why don't we have everyone do the 20-minute session? But I like to see people get better quicker. And I think people feel really good and their money is more like better invested when they really start to see the rewards really quick. So you can have someone in 3 days come back and like, dude, I'm already like feeling it. Like,
right.
Instead of like, hey, usually session 15 or 20, that's when people start to feel it. And that's pretty much the norm. So if you're going by that metric, 15 or 20, like you're waiting 4 weeks or 3 weeks before the patient notices anything. And some patients, it's like, you kind of are like really questioning it at that point, right? It's been 3 days. You're like, this is...
I mean, I've seen people come in here and feel a result the first day.
Yeah, I've seen it. Yep.
Many times.
Yep.
Actually.
Yep. I've seen it many times too,
So what types of mental health conditions are most commonly treated with TMS? I know depression is one.
Yep.
What else do you see that it works well with?
So there's, let's start with the FDA indications. So obsessive compulsive disorder works. It's FDA cleared for obsessive compulsive disorder. For smoking cessation, which we're probably going to see some approval for stuff beyond smoking cessation soon with that same modality. Anxious depression, of course. And then anecdotally, I've seen it work for ADHD, people with migraines, people with OCD, that's FDA indicated for OCD, PTSD, alcoholism, all sorts of different, there's protocols for tinnitus, there's protocols for pain. Pain doctors are starting to buy these because it works really well for pain, especially neuropathic pain with the nerves. But yeah, essentially any psychiatric condition, you can see some benefit from TMS because most of our patients have comorbid conditions. They don't just have depression. Usually people come in, they have a couple different things going on, and they usually see great benefit in all those areas. So,
how do you explain the benefits of TMS to someone who's skeptical or unfamiliar with it?
Yeah, I would say with someone that's skeptical or unfamiliar with it, if you just think about it in terms of the ailment is typically due to we are lacking something. So we're usually lacking one of those neurotransmitters. And you think about what like jump starting a car does and what we're doing by firing those neurotransmitters, we're essentially, we're jump starting our brain and we're calling for the body to make more. And I would say 90% of the patients that come in here are skeptical. Most of them are. I was skeptical when I first saw the machine.
Right.
I'm like, what the hell is this thing?
Right. I was skeptical too. Yeah. I can tell you that much.
But when you like really think about what it's doing, like, oh, okay, well, that makes sense. So we have a shortage of this. How do we make more? Oh, we stimulate the brain to make more. Like it makes perfect logical sense when you really think about it and you really start breaking down the science behind it. But yeah, I would say most patients are skeptical, and I try to get them to that 15 or 20 sessions. And then I also, try to make them comfortable. Hey, we'll, if it doesn't work, we'll give you your money back, or we'll treat you till it works, right. And that makes people feel good.
I think that's one of the things that we do here at Camelback Integrated Health and Wellness is we've got 100% money back.
Yeah, we'll give you your money back, and
if for someone that goes through the program and says it didn't work, we'll give them their money back. And I don't think we've ever given a refund.
We've never given anyone's money back. They've never, asked for their money back. I've never had a patient not respond. So we try to put those, rest those concerns. And they're like, well, what if 60 sessions isn't enough? I'm like, well, we'll treat you till you feel better, So.
What makes TMS different from other forms of treatment like medication or talk therapy?
Yeah. So for the medication, definitely you get to avoid all the adverse side effects. So obviously weight gain is a big one for a lot of people, especially people that want to stay healthy, maintain active lifestyle. It can really harm your metabolic system. So typically weight gain, there's some sexual dysfunction, which is, obviously an issue with most people. And you get to avoid those side effects. So TMS is a therapy that really has none of those adverse side effects. Most people stop taking medications due to some of the side effects.
Right.
So
now, so for TMS to be covered by insurance, it used to be they had to try 4 different types of medications. So it was treatment-resistant depression. Right. That kind of doesn't make sense to me. Explain to me, like, why do they have to try out 4 different types of medications? But now I think it's either 2, it's gone down to 2 and sometimes even 0.
Yep.
Right?
So for some different insurance carriers, like the VA, so TRICARE, and then there's some good carve out plans that you see, like, maybe Mayo Medical offers one, and I don't know all of them. But oftentimes you will call on some of these plans you haven't heard of, and they're like, oh yeah, there's no prior authorization needed. They're all set to do it. And you're like, wow. And that leads me to like think one thing, because insurance companies aren't dumb. They're not in the business of losing money. No insurance company is. So my thought is like, okay, well, if they're so apt to give this treatment first line now, well, there must be some return, because they ain't dumb. They're not going to give a $10,000 treatment away for no return.
Right.
So I'm thinking that they must see, hey, these people that are completing TMS, there's less office visits down the line. There's less medications we're paying for. There's less hospitalizations. There's other things going on because previously a lot of those insurance payers, like there was no way you were getting it approved unless they had to go through all those step therapies. Now it's different. Now it's, they approved it in children, like 14 and up. They approved it in geriatrics now. So you think about all these different things that are happening. And the insurance companies, they're in the business of saving money. So if they want something to be first line, that's usually like, it's cheap. Okay. That's what I think. When they want something first line, it's cheap for them.
Right.
This is not a cheap treatment. Right. So when you're trying to get a drug for a patient, they're like, hey, you got to try this drug from 1982 first. That's, 6 cents for a bottle of 30.
Right.
So, they're cheap, so that just makes me feel like, what they're doing with the TMS now is like, okay, well, it must be cheap to them somehow,
right.
a cheap patient for the insurance company is a well patient, right?
Right.
Maybe not for the hospital system, or for us, right? But I mean, we want all the patients to be well. But they want people to be, they don't want them coming to the office. They don't want them getting on a bunch of meds. They don't want them going to the hospital,
Right.
So, you kind of look at it like that. You can start to, okay, maybe there is something to this.
Should someone consider TMS by itself, or is it better paired with other modalities?
Definitely paired, because to get into the state you were, there had to have been things going on. So, typically you just don't like fall into a state of depression. Like a lot of times it's like, okay, you stopped working out, maybe your wife left you, or maybe, you're using drugs and alcohol, or you lose your job, or like some kind of like, sentinel event has gone on, or, you've let something get really out of control or snowball. And you can't just like re-regulate everything, like feel good and then like go back into that, the dark area. Your body's going to say, hey, we don't need all this serotonin, dopamine, or epinephrine. We have way too much of it flowing around. Let's cut back a little bit, and then like you're right back where you were. So,
okay.
You got to change the environment around you, or change your environment in which caused you to be in that deficit in the first place. So, we can help by giving you the capability back to have the motivation and have the energy to participate in life again. But you can't not. You'll just go right back.
Like, what are some of the top other modalities or things that you recommend for somebody that's going to start TMS to help them get through their depression, their anxiety, their PTSD, or whatever?
So definitely. So a couple big ones are connection, like being around other people. That's a huge one, because other people around you notice even before you, if you're doing TMS.
Right.
Sometimes it's like I'll have a couple come in and like, husband's bringing his wife and wife's very depressed.
Yeah.
I'll ask the wife, hey, how are you feeling? You feeling like it's working? I don't know. They're 15, 20 sessions in, and then the husband will be behind her, going,
it works.
It's working,
Right.
So sometimes, and if you're doing that alone, or you're not around family or around friends, you miss out on that kind of experience for someone to say, hey, look, you're acting different. You're coming alive. So definitely connecting with others is a big one. So the isolation is a huge, in my opinion, kind of push into those depressive type symptoms. So don't isolate is big. Exercise is big, because once we get that dopamine going again, and once we get those neurotransmitters flowing again, we want to be able to, keep those firing. So going to the gym, getting that workout in, getting that high end, doesn't just have to be going to the gym. You can walk, you can do just anything active, play sports, getting out, getting natural light, not being inside that dark space I was talking about. That's a big one. Getting outside is a big one. Adequate rest is a huge one. And, we know that not getting enough rest can cause your brain to kind of break down. And then, talk therapy is really helpful, but sometimes you get that just hanging around your friends. So I would say those are the big ones.
Okay. Can you walk us through what a typical TMS session looks like for a patient? I guess you can start with the brain mapping.
Yeah. So the first thing we want to do when we're getting a patient set up for TMS is we do something called cortical mapping. So our job is we need to find the landmarks. Okay. So we're working with this part of the brain called the dorsolateral prefrontal cortex, and we're working on the right side. So what we do is we actually position the helmet towards the back of the head, and we fire the machine or turn the machine on a part of the brain we call the motor cortex. So what we're looking for is movement in the hand. So once we turn the machine up enough to where we get just slight movement in the hand, we start to turn it down. So what we want to see is the minimal amount of energy it takes to get that hand movement, thus telling us we're firing neurotransmitters, because we're firing neurons. The hand's moving, we're firing neurons. So after we know that we're giving enough energy to fire the neurons, we know the landmark is 6 centimeters forward from that spot that caused the movement of the hand. And we know the dose to give because it was the minimal amount of energy it took to move the hand. So we rotate the helmet 6 centimeters forward. For most people, it's right at the top of the eyebrow. And then what we do is we have that, we call it a motor threshold setting. And if you think of the term threshold motor, it's the threshold of energy which causes a motor movement. So that's what we're looking for. We're looking for how much energy it takes, or the threshold in which to get the motor neurons moving. So that's how we know how much energy to deliver to somebody. And everyone's different. People that are really anxious, like they need very little motor threshold, like Desiree, who works here, she goes in the TMS chair sometimes, and I barely turn the machine on her. Her arm's like flailing if I barely touch it. And then there's some people, I think you have a pretty high one, where, you crank that thing up and you barely see any movement. So
why do you think that is, that there's more movement with her and less movement with me?
Because I think that some people may not need it as much as others.
Okay.
So that's a very interesting point. Or people like you, and there's some other people that maybe they didn't need it quite as much. They won't see the huge yield. They definitely see some benefit, but it's not like somebody that's in a dark room for 10 years doing TMS versus you doing TMS, right? It's not going to be as big of a gain of function. But people that are very, 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 very depressed, we got to crank that machine very high. People that are pretty stable and they just want like a little extra boost, and they want, maybe to optimize what they have going on, they may be on the upper end. So that's someone like you, someone like Joe, some other people that have came on and talked about it. I usually find their motor thresholds pretty elevated as well.
Okay.
So I think people that are pretty stable are pretty, got their stuff together pretty well. People you don't see, like, at least on the outside, really going through it all the time,
Right. Okay.
You can
Gotcha.
really feel it.
Okay. Do you have any favorite success stories, patients who really stand out in your mind?
Yeah, I mean, there's been a couple. I had a husband and wife. That's why that story kind of stuck in my head. And he spent all sorts of money on all sorts of crazy treatments. He's doing like ketamine treatments. He's doing I think they went and did like ayahuasca, like all sorts of different stuff. And he was willing to do whatever. Like, I was like, this is how much money is. He's like, I don't even care. He's like, we gotta do something. And she was so depressed. She would just she couldn't even talk. She'd just start crying. And then she'd be really irritable and angry too. And she's the one where I started to ask her, hey, how's TMS working for you? And the husband was behind her like, this is really good. So she was a really extreme case, and she came back very quickly. I think it was about like a week where I saw a huge change night and day. So that's probably one that sticks out the most, but there's been hundreds.
Right. Yeah, I can think of just a few people off the top of my head that I've seen drastic results, life-changing results for some people. Who's not a good candidate for TMS?
Yeah, that's a good question too. Obviously, TMS, we're firing a magnet, right? So it's using a magnet. So if you have anything that's magnetic in your head, right?
Okay.
Yeah, so we don't want to be turning on a magnet when you got something magnetic in your head. That can be really messy, right? So we don't want to do that. People that may have electrical stimulating devices implanted in their head, or stimulators in their chest area. So we have 32 inches, I believe, from any kind of ferromagnetic objects. Also, people that are actively manic, or psychotic, we don't want to do, because people that are psychotic, they usually have too much dopamine in one area, not enough in the other, and giving them more can make them more psychotic. We don't want them firing more dopamine when they already have a little too much.
Okay.
So that's another contraindication. People with seizure history, of course, because we're stimulating with electricity and magnets the brain, so it can cause a seizure. Very rare. It can cause it in people that don't have previous seizure history as well, but it's very rare. I believe 1 in like 10,000 or something like that. But those would be non-candidates.
Okay. What are some of the myths or misconceptions about TMS?
That it hurts. So that's something I hear all the time. It's a little uncomfortable at first, but most people, after they do it like 5 or 6 sessions, like they're on their phone, like they're napping, So that's a big misconception. Or they think of the old movies, where they got like the bite block in and the doctor's coming in with the paddles right. So it's for the most part, it's pain-free. There is a little, some people have a little bit of a headache the next day. I would say that's the biggest one, that it's like painful. It's going to hurt, that's the biggest misconception.
Okay. How do you see TMS fitting into the future of mental health and addiction treatment?
Yeah. So I know in Arizona, it's still kind of getting its footing, but we look at, around the country and around the world, it's really kind of taken off. I think we're seeing great results with TMS, and more people are learning about it and hearing about it. Honestly, it'd be awesome to get a TMS machine in every clinic. It would be. And it makes you feel good as the provider, knowing that, you feel pretty confident that your treatment's going to work for this patient. I don't know how many times, like, I'm sitting there when I'm not using TMS, I'm like at a hospital and I'm just like, oh God, I hope this works. Like, for their sake, I really want them to get better, but this is a really tough case, and I don't know, I'm unsure. I don't want them to be unhappy with me. I don't want them to walk out feeling worse than they did, or walk out not feeling any different, So, for a clinician and for the client, it would feel really good knowing that you're giving something that is most likely going to work.
Right. Yeah. Yeah, I just love that it's non-invasive. People can drive to the clinic and drive home.
Yep.
There's no side effects. I haven't seen anything else out there that works like TMS works. Because it always works. There's no side effects. It doesn't affect your appetite. Mm-hmm. You're not going to gain weight. You can drive to the clinic. You can drive home. All the things there's just no reason not to give it a shot. So I'm really excited about the future of TMS. Yeah. We have 2 machines here, and it's just becoming more popular, and more people are able to utilize the treatment. So I'm into it.
Yeah, when we did our dinner, like I was telling some of the therapists, I was like, I challenged them. I was like, bring me your toughest patient. Like,
right.
If you don't believe in it, if you're skeptical, and we were doing this at the dinner, I was like, bring up, and obviously we can't extend this to everybody, but I was like, bring me your toughest patient. I'll treat him for free.
Right.
Like, if you really you want to see this thing in action, send him to me.
Right. And it's, right now we're getting a lot of referrals from other providers that don't offer TMS.
So I had to buy another machine.
Yeah. So yeah, once more people, it's interesting. Like, once more people have the TMS machine, more people are becoming aware of it. So more people are going to start wanting the treatment. Right now, we're one of the few providers in Phoenix that offer the treatment.
Yep.
So it's nice. And I'm just grateful that we're able to offer it.
So am I.
So what are some of the other, I guess, some of the other newer treatments that are on the market today that you're excited about?
So definitely a big evolution in the medicated assisted treatment offerings. So many people, even though the medication's been out for a little while, just like at TMS, it's been FDA approved since 2006, or 2005, I think. It's a long time, you know. But so for opioid use disorder, we have long-acting injectable medications that can, keep people essentially opioid-free for 6 months, 8 months, after a couple injections. So different long-acting injectables really have a lot of promise. Is one thing I'm really excited about. And then all of the different wellness stuff we're learning and all the longevity stuff and seeing how it's really benefiting people. So I know we got the cold plunge at the residential, and I already knew because I started doing it. You kind of got me into it and how good I felt after. But it's people are starting to see that these different health benefits that, they usually see as maybe taboo or see them online, or a certain, set of people would be doing those things, like the Hubermans and, those kind of people. But then they try it and they're like, damn, I feel really good.
Right. I mean, watching someone's anxiety go from a 10 out of 10 to a 2 out of 10 in 3 minutes, after
crazy.
3 minutes in the cold plunge. It's no medication needed for that.
No. And you feel, sometimes I'll do it and, I'll come out and I explain it to people, I feel like my body had a Mentos, that's how I feel for 3 hours. It feels really good.
Right.
And it's, they say it, what is it? It's just as powerful as cocaine or more powerful than cocaine.
Right.
The dopamine.
The dopamine. Yeah. The dopamine increases dopamine by 250 to 300% for several hours.
Yep. Cocaine's 20 minutes, right?
Right,
so
right.
This is several hours. So seeing people learn about those different treatments and some of the longevity things like the methylene blues, the, what am I missing? There's some other things people are doing too.
NAD.
Plus.
What do you think about, what's your opinion of NAD? I've heard some mixed results lately, actually.
Yeah, so people that I know that have been doing the injectable NAD.
The subcutaneous?
Yeah, the subcutaneous injections. I hear that their energy levels are better, that they feel more rested when they wake up. So I haven't heard anything bad about NAD plus for sure. And you're seeing a lot more people that even call our treatment center. They're asking, hey, do you guys offer NAD plus? So, it's definitely catching on, and things usually catch on because they work for a lot of people. Right. So that's a big one. So that health and wellness space on that end, we're using it so much in the treatment industry now. It's it never did that before. It's usually here's meds, here's group counseling, and go to AA.
Right.
Now it's okay, here's meds, here's group counseling, here's the gym, here's the cold plunge, here's sauna, we're doing contrast therapy, we're doing NAD, we're doing vitamin bags, we're doing, different kinds of things. We're doing guided meditations, we're doing breath work, right? There's so many different things that are being incorporated now that, just it's so many more spokes in that wheel of healing.
Yeah. Mind, body, spirit.
Yep.
Yeah. What keeps you inspired to do this work every day?
I would say it makes me feel good, so definitely for my own recovery, I feel like it's kind of gaming the system for myself. I've always felt like I've got more reward helping somebody than ever getting anything. I don't know if that's just me, or maybe you feel that way too, but it feels really good to give. And much better than receiving. And I feel like the more I give, the more I get, which is pretty cool. Cheat code. Mm-hmm. It's the more you're able to give back, it's the more I give, the more I feel like I'm blessed in other areas.
Right. I mean, I think about AA, and I think about doing 12-step work. And the reason why I sponsor someone isn't necessarily to help them. Right. I mean, I sponsor people. I do service work. Yes, I am helping other people. Right. But really, at the end of the day, the reason why I sponsor people, the reason why I chair meetings, the reason why I do service work is because I want to feel better.
Exactly.
At the end of the day, that's it. I want to feel better. I want to stay sober. I want to feel good about my behavior. I want to feel good about my life. I want to feel good about the things that I do. And that's why I don't lie, cheat, and steal, because I don't want to carry around that guilt and that shame, which makes me feel terrible, which is what would lead me potentially back to drink or drug.
Yeah, I feel like it's, for me, I feel like growing up, it was always about what can I get? What can I get? What can I get?
Yeah, right,
and it's like there's all these people in the world. It's like they're always so obsessed with what they can get and, what they have and how can they get more. And, I've learned that, and so I think this is like a good cheat code. It's like the more you focus on helping people and giving, the more you just get. It's weird. It's a weird concept.
Call it karma. Call it
what it is,
whatever you want to call it.
But it works. I'm like, if I'm going to donate money or like help somebody out, and I'm like, damn, I really don't want to do this. It's like, like whatever, help someone with fix their tires in their car. And it's like, nobody's going to know I did this. And it's like $1,000. Like, I don't really want to do this, And then you do it, and then something like really cool happens the next day, and you're like, "That's why. I know that's why."
Always.
So yeah, for sure, that happens. All the time, and I'm like, and I'm always able to look back, and I think that keeps you wanting to do more too, because you're always able to relate it back.
Is there anything I missed? Anything else you wanted to talk about? Any other questions I should have asked you?
No questions you should ask. I'll just touch on TMS. The affordability, is often not discussed. TMS used to be a really expensive treatment. There's so many different ways to get TMS either covered by insurance now, and very affordable cash rates, payment plans, and it's not as expensive as you would think. So with people that want TMS, they're interested in TMS, we always try to find a way to make it equitable. We want everybody to be able to get it. And sometimes, we have to work our magic and move things around, maybe move appointments around and stuff like that. But we want everybody that's interested in it. And, maybe they don't have the means altogether right at that moment to work with us to be able to figure it out. So we want it to be equitable.
Okay.
So that's one thing I want to put out there, because I think people, they look online at the cost of it and they get automatically, if you type in cost of TMS, you're going to see $200 a session. And then you're going to think about what I told you, 70 sessions. You're like, damn, it's 15 grand.
Right.
That's a lot.
Right.
So if we're doing theta burst sessions and 2-minute sessions, there's lots of things we can do to make it affordable for people.
Awesome. Well, Dr. Robbie, thank you so much for your time today. I appreciate you.
Thank you.
And for anyone that's watching or listening, if you or a loved one is struggling with mental health or addiction, you want to learn more about TMS or any of the other things that we talked about, you can give us a call, 480-618-5430, or you can visit camelbackrecovery.com. Thanks for listening. Thanks for watching. And I will see you on the next episode. Thanks so much for listening to I Love Being Sober. I hope you got something valuable from today's episode. And if you're looking for more resources on recovery, mental health, or any of the therapies we talk about, head over to camelbackrecovery.com. You can find more episodes, blog posts, and ways to connect. Until next time, take care of yourself, keep growing, and keep living a kick-ass sober life.